Our next speaker is April Morrison, and she is a DNP student here at East Tennessee State University as well. And her topic today is breastfeeding, evidence-based clinical guidelines every healthcare provider should know. April.
And my name is April Morrison. I'm in my final semester here at ETSU. I am a full-time student on the Family Nurse Practitioner track in the BSN to DNP program. Over the course of my program here, I have become a certified lactation consultant as a result of my interest in breastfeeding through my DNP project. Again, thank you so much for letting me speak here today. Why breastfeeding? The American Academy of Family Physicians actually has a statement stating that family physicians, general practitioners, should know how to assist, support, and manage a breastfeeding mother, her child, and then how can we support that family? In my clinical rotations between women's health, pediatrics, family, I notice a disconnect. You go to the pediatrician, the mom comes in with breastfeeding trouble. Can you help me? The pediatrician says, no, why don't you go talk to women's health? Okay, so we go to women's health. I go to women's health and the mom comes in, I'm having trouble breastfeeding. Why don't you go to peds or WIC? I thought, who knows about breastfeeding? So I'm like, wait, let's go talk to WIC. I go to WIC. WIC's like, yeah, we can help. I'm like, what do? We give them these papers. Really? And we see moms come in time after time with recurrent bouts of mastitis, yeast over and over and over again, breastfeeding frustrations that lead them to stop prematurely. So that really spurred my interest in breastfeeding. So, as a clinician, let's find out what we can do about this. A very interesting fact, you may say, I hardly ever see a breastfeeding mom or a baby who is being breastfed. Actually, there was a study that came out in 2011 stating that 44% of mothers go and see their general practitioner within the first 10 days following the birth of their child. So this is something we very well may see, even on a regular basis. I'm not forgetting anything. I'm going to talk quickly. It's not because I'm nervous. When I'm nervous, I talk slow. I have a lot to cover, so let's move. I don't have anything to disclose. These are my objectives. I apologize. I'm not going to read them. We're just going to get running. Let's learn what breastfeeding is. So I'll make sure we're on the same page. Breastfeeding definition is a baby who's only receiving a mother's breast milk, aside from maybe a vitamin or a mineral supplement. I know that there's some standards out there that call for some vitamin D supplementation, but this baby's not receiving anything else, no water, because we know that breast milk is a sufficient amount of hydration for an infant. So no infant formula, no other additional fluids. Formula feeding, this is what other people think is the opposite end of the spectrum. This is a formula that's made in a factory. They are not bioequivalent, and we're going to look at that here in just a little bit. But that is a baby who's only received infant formula, no breast milk supplementation of any kind. Supplementary feeding. This is an infant who is under the age of 6 months and has some supplementation in addition to the breast milk. This may come in the form of a mom who might think her baby needs water. Or a mom who says, I'm not making enough breast milk and I think my baby's hungry, so I'm going to give it a bottle. So that's a supplementation. Complementary, this is an appropriate step. This usually occurs around the age of 6 months. We start introducing what we refer to as complementary foods in the addition to an adequate intake of breast milk, okay? So I hope we're all on the same page because those will kind of set the stage as we move forward. Why breastfeeding? Why in the world does this matter? Well, there's several benefits, and these are three of the biggest ones that a lot of organizing bodies like to emphasize, especially when we educate our mothers. There are infant benefits, maternal benefits, and economic benefits, not just nationally speaking, but even personally speaking on your own budget level. Infant benefits, there's a lower incidence of SIDS, a lower incidence of necrotizing enterocolitis, a lower incidence of asthma, decreased rates of type 2 diabetes, obesity, and one that I really love to emphasize to parents is your kid is going to be smarter, maybe even smarter than you, because maybe she wasn't breastfed. Maternal benefits. Mom says, why in the world should I breastfeed my baby? Well, guess what? There's a lower incidence of gynecological cancers. There's also an increased rate of maternal-infant bonding. As we're going to learn about some of the hormones involved in breastfeeding, we also have learned that those hormones that happen as a mom is feeding, that helps her to bond better with her child, and that can result in a decreased level of postpartum depression, which I'm sure a lot of us have seen. The mom is also kind of have a decreased incidence of type 2 diabetes. Economic benefits. We are penny pinchers here in the United States. We hear all the time about healthcare spending. We're going to look at some of the guidelines here in just a minute. But if a mom were to follow the guidelines, she would save an astronomical amount of money. In fact, they did a study. I believe it was Melissa Bartik. She came out with a study that said if 90% of moms in the United States would adhere to the breastfeeding recommendations, annually we would save $13 billion, with a B, billion dollars. And if 80% of moms would adhere to those same guidelines, we would see $10.5 billion saved in healthcare spending. Now that's looking at some of the more common illnesses that patients present with as a result of not breastfeeding. We know that babies who are formula fed are going to have an increased rate of ear infections. So they took about 5 or 6 of these most common diagnoses, looked at how much those cost in children who have been infant formula fed versus those who are breastfed. Did a cost analysis. That's where those numbers came from. That's pretty significant. So guidelines. Tons of agencies have guidelines. The American Academy of Family Physicians, American Gynecological Association. But these 3 pretty much sum up what everybody is saying. We've got American Academy of Pediatrics, World Health Organization, and the Health Department. They all say the same thing, exclusive breastfeeding to 6 months of age. And then, when do you quit? Well, the Department of Health and Human Services says for up to 2 years and beyond. If you look internationally at infant weaning rates, the infant average age, does anyone want to take a guess at what the average age an infant is weaned from breast milk, internationally speaking? Any guesses? 3 years of age. Do you know what the average age in the United States is? It's about 6 weeks. 6 weeks. It's about 6 weeks. What happens at 6 weeks? Mom goes back to work. Yes. All right, so we're going to talk about that too, okay? All right, so let's look in America. Where are we? Where have we been? Where are we now? Where are we going? You can see down here on the, we're going to fancy pointer, down on this left-hand side of the screen, those are the different types of feeding. These 3 up here, these refer to the ones who receive supplementary. Remember, supplementary is both infant and breast milk. Okay? Then I want to focus on these down here. Specifically the one on the bottom, the exclusive breastfeeding. In 2009, the CDC came out with their breastfeeding report card that said that in 2009, 16.3 lousy % of infants received exclusive breast milk up until the age of 6 months. All right, so where are we today? Today we are at about 18.8%. Nationwide, that's not looking so good. So then where is Tennessee? Look, we're at 15.4% in 2014 according to the CDC breastfeeding report card. We are lower today than where our nation was even 5 and 6 years ago. So healthy people come out with a goal. They have goals for all types of breastfeeding. They have goals for ever breastfed, breastfed for the first 6 weeks. So they have all these different goals, but the one goal that I want to focus on again is that exclusive at 6 months. And as you can see, they want to see about 25.5%. We only got about 6 more years to get there. And we still got a ways to go, okay? To understand how to fix some of our breastfeeding problems, to help our moms not be as frustrated, we got to understand how breast milk is created. I'm going to focus specifically on 3 hormones. Let's talk about progesterone. We all learn in women's health that is the pregnancy hormone. So as a mom, as a baby is conceived, we know that progesterone hormones are going to increase significantly. A mom, her body has receptor sites. When she becomes pregnant, that receptor site is filled with progesterone, okay? That's what helps her to sustain the pregnancy. Around the area of 16 to 22 weeks, we see a process called lactogenesis 1. There's 3 stages of lactogenesis, all right? First week, lactogenesis 1 begins when we start to see an increase in a hormone called prolactin. Pro meaning for the creation of milk, okay? So about 16 to 22 weeks, a mom can start actually expressing colostrum. That's that thick, sticky, brown, kind of yellowish colored milk that a baby is going to get at the very beginning of life. That's the stuff we want to make sure they get. That's so vitally important. So she starts to create that. And then we have lactogenesis 2. This begins with the birth of the placenta. As the placenta detaches from the wall of the uterus, we see a sharp decline in the progesterone levels. So those receptor sites then open up. We have prolactin, which comes and attaches to those receptor sites, and that's when our milk supply really starts to ramp up. Okay, so that's why when a mom has a baby, about 3 to 4 days postpartum, she comes in the clinic about to explode. She says, I am leaking everywhere and I don't know what to do. That's because those progesterone levels have decreased and her prolactin is now through the roof because her body is now ready to feed her baby. All right, lactogenesis 3. I often often think of this as the alternative lactogenesis phase. A mom can choose whether or not she goes through this phase, and this phase can continue on. This occurs when we have a variation in the hormone levels, and that occurs with oxytocin and the prolactin. Oxytocin is a hormone that causes the smooth muscle cells around the milk ducts to contract, helping the body to expel the milk out the nipple and into the baby's mouth, okay? Oxytocin levels rise. If any of you women out there have ever had a baby, your body is programmed for prolactin. You hear a baby crying. If you've ever been lactating in a restaurant and you hear a baby crying, what happens? Oh my gosh, I got a milk letdown. So oxytocin works in a couple of different ways. It's like a muscle memory, just like we have whenever we work out. It's a muscle memory. You can smell something. If you smell a baby, some moms have that. They smell a baby and they get a milk letdown. But also it comes from stimulation. A baby suckling at the nipple, that causes an increase in oxytocin levels, pushing that milk out. The baby says, I want more. And we're going to talk about how a baby can facilitate that. Oxytocin levels rise, the milk gets squeezed out, the breast empties. As the breast empties, we're going to see these pulsatile increases in the progesterone. That's that green line, okay? So a mom says, I'm not making enough milk. Let's empty the breast more frequently. We call that an interbowel interval. So if we want more milk, it works like a factory. We got orders in, we got product out, okay? So if we want more product out, let's get some more orders in. Let's feed that baby more frequently. That's a short interbowel interval. Weaning, we think of that as long interbowel intervals. That's when we are saying, okay, let's do a 3 or 4 hour spread between the time that me and the baby are going to connect, okay? And that's going to cause weaning. The body gets the signal, hey, the breasts are full. Let's slow down. Let's not make as much milk, okay? And as you can see, this is just a little diagram here showing how the baby is suckling and the HPO axis and all that's involved. I hope everyone understands because it's really important as we move forward. This is huge. How many times have you seen in the clinic, mom comes in, I can't do this, great, here's a bottle. There's actually very few people who cannot breastfeed. This is just our guidelines within the United States. According to the CDC, the only ones who cannot breastfeed is a mom who has HIV, someone who's taken antiretroviral medication, someone with active untreated tuberculosis, T-cell lymphoma, illicit drug use. Okay, let's define this. When we say illicit drug use, we're talking about a mom who is not currently in a rehabilitation program. This is a mom who's getting crack off the street or buying Suboxone from her friend. This is not the woman who is in a clinic who's under the watchful care of a clinician. If someone's getting it off her friend off the street, we don't want that mom breastfeeding, okay? We don't know what she's getting. We don't know where she's getting it. However, if a mom, say a mom is in a Suboxone clinic, she's just recently had a baby, but she's following protocol, she is meeting all the requirements according to the clinic, it's okay for her to breastfeed, okay? Someone who's on chemotherapy, radiation, however, even with radiation, there's just a little time when that mom should not breastfeed, and maybe we might want to represent or tell that mom when she's doing her therapy to pump and dump. That way, when that short interval when she can't feed is over, she can go ahead and restart, and it's okay. AAP says that they added some untreated brucellosis, and then galactosemia. That is where a baby is not able to metabolize or process milk sugars very well, and it's actually neurotoxic to the child. But that only occurs in about 1 in every 60,000 births. But again, that's one of those standardized labs that we get on newborn infants. So you're going to know whether or not your child has that as soon as they're born or shortly after their lab work returns. As a clinician, we need to know how can we prepare our moms before they have a baby. So let's educate them on the breastfeeding benefits. We've already covered that. So really champion those with your moms. Elaborate on expectations following birth. This mom comes in the clinic. She comes in day 3 for her postpartum first appointment. She's busting, and she says, what do I do? And you're like, oh, don't you know you're supposed to feed your baby like 8 to 12 times a day, 140 minutes? How's that going for you? What? They had no idea. So let's be preparing these moms. Let's tell them what's expected of them. So if a mom comes in and says, I think my baby's so hungry, well, how frequently are you feeding them? Oh, every 4 hours. I remember my mom had a baby when I was 15, so I got to really experience it. And I remember she struggled with breastfeeding so bad. And she said, I learned this recently. She said, you know what they told me? I said, what? She said, they told me, feed my baby every 4 hours. She was breastfeeding. Feed my baby every 4 hours, and if they're hungry, give it a bottle. Mm-hmm. An infant's stomach is the size of a cherry in those first couple weeks, and maybe a ping pong ball if you're lucky. Sorry, but if I had a cherry-sized stomach and I'm getting some milk, you better feed me more often, okay? So let's talk to those moms about that expectation. Let's dispel myths. One of my favorite myths is antepartum nipple buffing. This used to be a real practice. In medical books, they would say, you got to prepare those nipples because they're just not going to be ready. It's going to hurt. So get you a terry cloth the month before your baby's due and buff them up real good because then it's not going to hurt. Oh my gosh, no. Nipple care is such an easy thing because the milk already has the things in it that take care of those breast tissue. So we tell a mom, hey, whenever you're done breastfeeding, just let those things air dry and then you're done. You don't have to worry about it. There's no preparation. Smoking, mom says, I smoke, I'm out. No, you're not getting off that lucky. Okay, a mom who smokes, we always want to encourage them to quit, always, and we have great programs here in the city of Tennessee that help our moms quit smoking, okay? But one thing we do want to tell them is please don't smoke around your baby if you're going to do it. Go outside the house, change your clothes, take a shower before you breastfeed your baby. Also, she needs to be aware, a mom who smokes, the chemicals in cigarettes are going to combat those hormones that help her to make breast milk. She's not going to have as good of a supply as a mom who doesn't smoke. So she needs to be aware of that. So she might be a mom who needs to increase her interval, okay? She's probably not going to be happy about that either. Alcohol intake. We know in pregnancy, no alcohol. What about breastfeeding? Mom comes into your office for her whatever 1 month baby visit, and she's like, oh, my anniversary's around. You're like, congratulations. She's like, yeah, I really want to have a glass of wine, but I can't because of breastfeeding. Wait. According to the guidelines, if a mom is breastfeeding and wants to have 1 5-ounce glass of wine, 12 ounces of beer, it is acceptable. Breast milk works just like a liver, okay? Our liver metabolizes alcohol in our bloodstream. After a little while, the alcohol's not going to be there anymore. It's the same with breast milk. Alcohol gets into the breast milk, it's going to metabolize out with time. A lot of these moms say, well, I had a glass of wine, I have to pump and dump. No, you don't. It's okay. But let's make sure that we are aware and make sure the mom understands we don't want her impaired. We don't want her going home inebriated and unable to care for her child. So let's make sure she understands. If we know this is a mom who's prone to alcohol, we need to have a good conversation with her. Substance abuse, we've already talked about it. Easing fear. Mom says, well, I'm going back to work. Why even start breastfeeding? We're going to talk about that in just a little bit. It is possible. And then a lot of dads are like, what am I going to do? I know a lot of grandmas say that too. What's my role if you're breastfeeding the baby? There's an amazing campaign out there called If I Could, I Would. And it's a whole campaign that helps to support fathers. There's educational material, and it's just a great way for men to know how they can support their moms. And there was actually several studies done where they've interviewed dads to see, do you feel a diminished role in your wife or your baby's life as they're being breastfed? He's like, no. That's actually the generalized statement from the research is that fathers don't feel a diminished role. Moms need to know about their legal rights, okay? A lot of moms think they have to go hide in the bathroom to go feed their baby. That is absolutely not the case. These right here at the bottom of the screen, where's it? Okay. Is that a mom in the state of Tennessee, it's not considered to be public or it's not considered to be public indecency or nudity. So if a mom's at a restaurant and wants to breastfeed her baby, the manager comes up to her and says, you need to take it somewhere else. No, it's okay for her. It's actually okay. Not socially acceptable in a lot of places, but according to the law, it's okay. Local governments can't prohibit it. If a mom's in a museum or a national or state park, it's okay. She can go ahead and breastfeed her baby. And also, the employees have to accommodate a mother. Accommodation is not a bathroom. So if a mom is at work, needs to breastfeed her baby, she can, in a way, come up to her employer and say, can you help me? And there's actually great reference material online that helps employers to know how to prepare their workplace to help these moms be successful. And I can give you guys that stuff later if you want it. I'm pushing the button. Nothing's happening. All right. Okay. This is the fun part. In order to be a clinician, to combat some of the problems that we see most frequently, we have to understand how to feed a baby. Honestly, I've never fed a baby. I've never had any. So I had to learn myself. I'm going to put on my little breast here. My mom made this for me. It's the first time she's ever made a boob. Okay. So let's first of all learn how to hold a baby, because if we know how to properly hold our child, we're going to know how some of these problems may have happened and how we can prevent them. This is my friend Sneaky. All right? So let's first talk about how we hold the baby. There are several different positions we want to hold the baby in, whichever is most comfortable for you. But some of the fundamental elements we want to remember as we're instructing these moms on how to hold their baby is we want the baby's stomach to be turned towards the mom. We don't want the baby to be held like this with his neck cocked aside. Do you get like this? No. So let's make sure that the baby is turned in the body towards the mom. Okay? There's a cradle hold. That's the traditional hold where a mom holds the baby with her forearm. And then, of course, if we're doing a cradle hold, we want to make sure the baby's actually turned in this direction, okay? This is not so much my favorite hold because we want to make sure the baby has free head movement. And this kind of restricts that somewhat. But whatever the mom wants, okay? And then we also have what's called the cross cradle hold, where I'm going to put my hands in between the shoulder blades. I'm going to be supporting my infant in this direction. I can, again, hold them on either side, and we know that we breastfeed on both sides, just depending on what's going on and how much the infant needs. There's what's called sideline. Oh my gosh, how many times has this happened? Mom is exhausted. Honey, go get the baby. Okay, mom's still lying in bed. The mom can lie in bed. She can lay the infant next to her, and that's called a sideline position. You can do both sides. There's also what's called a football hold, where again, the hand is in between the two shoulder blades. The spine is rested against the forearm, and again, the baby is turned in towards the mother so that its body is close, and then this is also another positioning you can use. It's whatever the mom prefers or the infant prefers. And honestly, as they age, the position is going to change, okay? They might be sprawled out everywhere. Positioning aids, a mom might want to have a pillow to help support the infant, a nursing stool to keep her knees up. We don't want the mom bending over because that can become uncomfortable and may lead to poor positioning. If the mom wants to use covering, she can use covering, and we want indirect lighting source. I don't want to eat with interrogation lights, and neither does a baby, okay? As a provider, as we instruct our moms, let's use a hands-off approach, okay? Because we want to enable our moms. We don't want to have to make them dependent upon us to do the right positioning. We want to enable them to do it themselves. If you must, do hands-on because they're just absolutely not getting it. Make sure you ask for permission. Let's talk about some latch fundamentals because this is where we get into a lot of problems. A mom comes in and says, I'm having trouble. The first two things you want to look at and to hear is visualization of the baby's latch, the mom's positioning, and then sound assessment. What sounds are you hearing? Are you hearing like smacking sounds? That's not normal. We really don't want to hear anything. The only thing we really want to see is a rocker motion and a suck-suck-swallow sound. So the baby has a suck-suck-swallowing. If we have an improper latch, we're going to experience things like pain. We get that frequently. We're going to get suckling sounds if they don't have a good seal around the nipple. And then, of course, white or compressed nipples, that's always a problem. So let's talk about the latch very quickly. Touch myself here again. And all this is going to make sense when we get through some of these problems that mom comes in with, okay? So this is how we do our latch. We have our infant positioned properly. The baby's held in very close. We don't want to hold them in too close. If I'm pressing in too closely with my infant, that can actually kink off a milk duct, and that can cause milk stasis. Milk stasis is a problem. Milk stasis can lead to a plugged duct. That can turn into an abscess, or it can turn into mastitis. All of these are big problems. If the baby is not held in close enough, that baby is going to have a nipple in the front of the palate. Feel the top of your palate in the front, those ridges. Imagine your nipple being on those ridges, repeated friction back and forth over and over. That's going to cause trauma. Trauma can lead to cracks. That can lead to yeast. That's an open source where we can get mastitis and all hosts of other problems. So let's keep that in the back of our mind as we're thinking about it. So we have the baby held. The baby is ready. I have my hands up between the shoulder blades. We want to align the baby's nose with the nipple. Okay? I would prefer to go get a drink up here than have to go get a drink down here. Okay, so what we're going to do is hold the baby in close. We got the nose to the nipple. The baby is naturally going to have what we call a gate response. It's going to open its mouth, it's going to lean its head back, and it's going to attach, okay? When the infant attaches to the nipple, we want to see more areola up here at the top than we do at the bottom. It's called an asymmetric latch. We want to see a wide angle of the infant's mouth, about 140 degrees or greater. We don't want to see any milk leaking around the mouth. We want to ensure that the lips are flanged open on the top and on the bottom, okay? We want to make sure we don't see the baby's tongue. We don't want to see the mom's nipple sticking out. All these things are going to be signs and symptoms that we have a problem, okay? I think those are the major ones. If a mom comes in and says she has pain, always assess the mother's positioning of the infant and the baby's latch. If none of those work, we're going to talk a little bit later about an infant oral assessment. And I know all of you got that totally right now. So there's this great tool called a lat tool. You can literally pull it out. It's online. You can pull it out when the mom comes in and says, I have problems. This literally takes you about a minute and a half. You can walk through your mom her clinical visit, and you can walk through some of the problems that she's having. So based on what we know about latch, which is preferred? Pick it. Two. Yes, exactly. That baby, see how close his little nose is to the mom? A lot of times moms who are like, oh my gosh, my baby's going to suffocate, they'll put like a little V right here and kind of press the breast tissue back. It's okay. We want that chin to be right in close to the mom's skin and also the nose too. And they can breathe. That's how it was designed. See, this picture here shows how the nipple is actually in the back of the soft palate towards the back of the mouth. So this is how, as a clinician, we know whether or not this mom's doing a good job, right? Let's look at infant growth. That's one of the big things we look at. We want to have a baby gain about a ½ ounce to an ounce per day. Mom comes in and says, my baby's not getting enough milk. If that baby has gained 4 ounces in the last 2 days, Mom, you're doing a great job. Keep it up, okay? Growth faltering. A baby comes in and they're not gaining enough weight. What could be some of the problems? Mom comes in and says, I'm only feeding my baby for 20 minutes every 4 hours. We might see some growth faltering with that because if you do the math, that's not going to add up to about 140 minutes a day. Could she be maybe compressing her breast too much and not allowing the milk to flow? Those are all going to be problems we want to look at if we have growth faltering. Stool count, that's something else that we look at. A baby who's breastfed is going to have a wide range of what is a normal stool pattern. They could have one every feeding, or they might only have one every 3 or 4 days. And again, wet diapers, that's something else that we look at. Colic, the mom says, my baby's colic. He cries for 3 hours a day, at least 3 days a week for 3 months straight. My baby has colic. He doesn't like my milk. No. How about we ask the mom, what does your diet look like? Maybe we need to do an elimination diet with the mom, have her eliminate some liquid dairy products and see if maybe the baby doesn't respond better to that. Because a lot of times they get to the colic phase and the mom says, I'm done, where's the infant formula? I need soy, I need rice, or whatever. But no, this mom can still breastfeed even though her baby has colic. Keep everything in the back of your mind that we talked about with positioning, because I don't have enough time to keep reiterating that, so I'm going to skip over that part. But a mom who comes in, the mom says, I am sore. This is her perception of pain that's going on. It may visually not be anything, but that's what she's telling you, so we need to evaluate it as a clinician. Does this mom has a history of Raynaud's disease? We need to make sure that she does not. If she does, she very well could have it in her nipples too, and that's going to cause a great deal of pain. Are we assessing her breast to see if she has mastitis or does she have yeast? And we're going to talk about each of those a little bit. Did we do the infant oral assessment, ankylosing? We all have a piece of skin called a frenulum that anchors our tongue to the bottom of our mouth. Sometimes a baby has that piece of skin at the front of its mouth, and that tongue is not able to move properly to get adequate stimulation to get that milk to flow. And that's going to cause a lot of pain, and it's going to cause milk to possibly back up in the duct as well. So a mom who comes in and says pain, we're going to look at her latch. Yeah, 5 minutes, oh God. We're going to look at her breast tissue, and then most importantly, let's get this mom to an internationally board-certified lactation consultant, IBCLC. Those are the pros on breastfeeding. So it is okay for us as a clinician. Listen, this is way out of my league. Go refer them. Go find your IBCLC in your community. Another management issue is inadequate supply. Remember, it's like a factory. The mom that comes in and says, I'm not getting enough. Let's get her perception of what is not enough. Is your baby white fist clenched? That's probably a good indication that maybe it's not enough. Is the baby having growth faltering? Is the mom a smoker? That's a good thing. Is the mom had a sinus infection recently and she's taking Sudafed? That dries up mucous membranes. That's going to dry this up too. Do we see hypoplastic breast? That could be a problem. PCOS, hypothyroidism, those are some of the things we could look at. Also, let's look at the infant to see for cues of inadequate milk supply, which we've already discussed. Does the mom know what a proper infant feeding cue is? If she's seeing feeding cues and then stuffing and passing in its mouth because she doesn't have enough time, that's going to prolong the interbell interval. Prolonged interbell intervals are weaning. Therefore, her milk supply is going to decrease. So let's kind of discourage moms if she's thinking she's got inadequate supply. Let's steer her away from the pacifier. Let's encourage the on-cue feeding. Let's make sure she understands what an adequate supply is. And then if she's not making enough and she is doing adequate feeding with her baby, let's even encourage her to do hand expression or even pumping in between to kind of increase her supply. Let's dispel the myths. The mom says, I'm drinking until I'm peeing all the time because that's what I heard makes you have more breast milk. It's not true. The woman's body is such that it's going to take from the mom what it needs because the body is programmed to keep that little infant who's helpless alive, okay? So even someone who is in a third world country, doesn't have adequate nutrition, probably doesn't have the clean water resources that we have, they are still able to breastfeed their baby. It's going to make the mom have some deficiency though. So let's do make sure our mom has enough nutrition and fluid intake, but those actually work irregardless. And then a mom comes in and said, I started exercising and my breast milk supply went down. No, maybe your exercise is getting in the way of your breastfeeding times, and exercise, again, does not affect your breast milk supply. So it's actually good for a mom to go as she's breastfeeding to exercise. This is less common. A mom who comes in, maybe this is the mom who wants to go back to work. I've been increasing my stimulation so I can increase my milk supply, and now I have a problem. I'm so engorged, I'm uncomfortable. Help me. This, we all know that oversupply, engorgement, stasis, if that milk stays in there, it's warm, it's sweet, it's dark, it's going to start creating bacteria. We're going to get mastitis. This could be a real problem. Let's look at the infant to see if the infant is experiencing problems as a result of the mom's engorgement. A baby who has reflux, this could be a mom who's making too much. That baby's getting too much to eat and it doesn't know when to quit because babies are obligatory swallowers. If there's something in that baby's mouth, it's going to swallow it. So if the mom says, well, my baby's still swallowing, I'm going to keep on feeding, well, the baby doesn't know when to quit until he gets sick, and then he's going to start regurgitating. A poor latch, if the mom says, oh, I'm starting to hurt so bad. If you had your mouth up to a water hose from a mom who's so engorged, you would try to clamp that off. So that baby is going to try to stop that flow and is going to try to get the milk to quit flowing so quickly, so it's going to bite down. Again, overstimulation. Is the infant gaining too much weight? Those are all things we look at. Teach the mom is supply and demand. Maybe she should only do one breast at a time. Or maybe we need to teach her about proper milk supply for going back to work, which we will talk about in just a minute. And then, hey, maybe she wants to donate some of her milk. There are lots of milk donation places around the country. And then we want to watch this mom for mastitis. Okay. Candidates, again, this is a real problem. Moms who have trauma to the nipples, this is an open source for that yeast to get in and cause a real problem. A baby who abruptly stops feeding. The mom says he was fine yesterday and he's not today. That's a good indicator the baby could have yeast. How do we know a baby has yeast? A lot of times babies have the white milky tongue. They're like, oh, that's so cute. We'll get a gauze and say, the mom says, baby, stop eating. Go get that gauze, wipe the baby's tongue or the side of the mouth or wherever that white patch is located. If it doesn't come off, that's a really darn good indicator that the baby's mouth has yeast. When we have these moms that come in with yeast or we suspect to have yeast, tell her we got to properly clean and or dispose of the toys, the pacifiers. If a mom is using a pump or something like that, she needs to make sure she properly cleans all of those things. And then nipple care. How is she caring for her nipples? Previous thought was clean those things with alcohol after every feeding. Oh gosh, they would be dry as a desert and cracked, and then that's an open place for yeast. Let's remind those moms, just put the breast milk on, let them air dry. When we have a mom with yeast, baby, mama both get treatment, diflucan and some nystatin. Okay? And if it doesn't work, the mom comes back a couple days later and says, this ain't going away. We might want to consider bacteria. Keep feeding the baby. Doesn't matter. She still can do that. Clogged ducts or pores. Again, this might be the mom who wears really tight clothing, a tight bra. She is not emptying her breast enough or the baby doesn't have a good latch, so she gets milk buildup. She might come in and, is this the one? Yeah, she said, I didn't have a lump yesterday. I woke up this morning, I had a lump right here. It's tender. It's not really red, but this is not right. Tell this mom to start feeding on that side first, okay? Because the baby's going to empty that one really good. And then in about 24 to 48 hours, that lump should expel. Warn her, it's going to look like a string cheese or a cream cheese or even a blob that expels out of her breast. Okay? We might even encourage her to do some hand stimulation to help that oxytocin to get going and really squeeze on those milk ducts to get that milk to flow. And then she can put some warm compresses or something like that. Mastitis, again, this is from too much milk. Being in the ducts, it builds up an infection on the inside. This can be very dangerous. The mom comes in, she says, I feel like I have the flu. I don't feel good at all. And she is very sore. She's very tender. The number one treatment for this is insufficient. So you're going to basically get some milk, see what the milk is growing, and then treat accordingly. And then you can give her some NSAIDs for pain or whatnot. And I'm trying to hurry, I'm so sorry. An abscess. This mom comes in and says, this abscess is really big, it's hot, it's red. This looks a lot different from the milk duct, okay, because it's an infection now. She said the milk in this breast looks a whole lot different from the milk in this breast. That might be pus coming out, okay? So let's make sure that we look at that ourselves. Don't just treat her and send her on, or don't just consult her. We need to make sure that we treat what's going on. This can be caused from a poor latch or a blocked duct that never got unblocked. Can be a real problem. Or moms with diabetes. That happens more frequently in these moms. They're already at increased risk for infection. We want to help these moms, encourage them to continue breastfeeding. They may only be able to breastfeed on one just due to the pain, but we still want to be hand expressing or pumping the other breast. This mom needs a surgical consult and then appropriate antibiotic therapy. Returning to work and school. Does the mom want to continue feeding her baby? Let's figure that out first, because we always want to support the mom's decision. So she says, I don't know, can I? Absolutely, you can still feed your baby and go back to work. And then, what does your support system look like? So that might be some research that she needs to do, but as a clinician, let's tell her what she can do according to that state. Does she want to continue? These moms don't have to have a freezer full of milk. All you really need is about 1 to 2 days of milk build up in your fridge. Because as you're at work, remind that mom, if your baby normally eats every 3 hours, pump every 3 hours at work. And that'll keep that supply ramped up so you don't drop off. And then we can even try to introduce power pumping. That's where you pump for 5 minutes, take a break, then you pump for 5 minutes again. And again, you get those increased levels of prolactin and oxytocin that are going to ramp up your supply. And then milk storage, you can keep stuff on the counter for about 4 hours, refrigerate it for 3 to 5 days, and then keep it in the freezer for 3 months. Her mom has twins. There is no way, right? Nope. Supply and demand. More demand, we gotta have more supply coming out. So it is absolutely possible. A mom gets pregnant. Crazy story. A mom was breastfeeding her 2-year-old, and all of a sudden she comes into the pediatrician's office for her 2-year-old's appointment, and she's like, he's wanting a drink of water after every time I breastfeed him. I just can't figure it out. And the physician was so intuitive, and he was like, you might be pregnant. Remember that 16 to 22 week mark where the prolactin levels begin to rise? Prolactin levels in the presence of progesterone creates colostrum. That baby was getting colostrum. He's like, this is not what I used to have. It's maybe the same volume, but it's just not the same. And so, again, it is possible for that mom to breastfeed. But the baby that's already breastfeeding may self-wean because they don't like colostrum, or they might continue. But if that mom is going to continue to breastfeed that infant even after the birth of her other one, the newest baby goes first, okay? We want to make sure the most vulnerable one goes first. Make sure she's got good nutrition. Relactation, this is a crazy story. There was an case study done on a grandmother who breastfed her grandchildren because the mom was unable to. I think the mom had passed away. It is possible if you've breastfed in the past, with frequent stimulation and the oversight of a clinician, you can actually restart your lactation and then induce lactation. It is possible. This may seem off the wall, but it is true. You can start breastfeeding even if you adopt a baby. If you have adopted a child and you want to have the experience of breastfeeding, it is possible, but you will never have the volume of a mom who's actually experienced the pregnancy. What is our role as a provider? We want to make sure we do lots of antepartum education. Even as a male clinician, you have the power to influence, you have the power to support and educate moms in their breastfeeding decision. When I first did this project, my husband was like, you can't do that. I said, why not? He said, because you've never breastfed. And I thought about it. I really didn't have a good answer. And I went to the American Academy of Pediatrics conference, the national conference in Washington. And at one of the sessions, we had a round table type of dinner. And I sat next to these strangers. I had no idea who they were, but he said, MD, it was 2 males. He said, MD, IB, CLC. I said, no, get out. I was talking with them, and it was 2 males. They are very prominent in the AAP. And they started the Breastfeeding Center of Pittsburgh. And they have just exploded the support and education that's available in that city. So don't worry about your gender. You have an important role. And we want to make sure that she has close follow-up. And then send them to a consultant, such as me or an IBCLC. And then make sure she's aware of the community resources.